Good morning, one and all. At the outset, I would like to thank my head of the department, Professor Dr. Devi Meenal ma'am, for giving me this opportunity. Without wasting much time, we will get directly into physics OSCE. It will be much like OSCE pattern, OSCE and DNB exams, either 3 or 4 questions per set. In some sets, there will be extended 2 or 3 questions. So there will be 4 to 6 questions in each set. First, identify the effect. The photon is interacting with inner shell or outer shell? Inner shell. So it is. What are the basic interactions of X-rays with matter? Photoelectric effect and Compton scatter are the most important one. So it is inner shell. So photoelectric effect. So the interaction here is photoelectric effect. What are the advantages of photoelectric effect compared to Compton scattering? Here it magnifies contrast and there is no scatter radiation and it is directly proportional to the atomic number Z. So we have to know one important formula for photoelectric effect. It is photoelectric absorption is directly proportional to the atomic number cube, that is Z cube, and inversely proportional to energy E cube. So as long as the atomic number of the substance get increased, the photoelectric effect will also get increased to the cube. So P directly proportional to Z cube, photoelectric effect. So what are the other types of interactions with matter? Compton scatter, pair production, photon disintegration, or the other things. So this is the Compton effect. Here the interaction is in the outer shell, whereas in photoelectric effect it was in inner shell. So Compton scatter is directly proportional to atomic number Z. True or false? False. Because it is independent of atomic number. Only photoelectric effect is directly proportional to atomic number. Compton scatter is not anyway related to atomic number. So Compton scatter is directly proportional to number of outer shell electrons and electron density, not on atomic number. Coming to next station, identify the device. My humble request is we have to write full answer, that is thermoluminescent dosimeter in exams. So it is thermoluminescent dosimeter batch. What is TLD batch made of? Dysprosium doped calcium sulfate, and other thing is lithium fluoride, either 1 or 2. And what is the permissible whole body radiation dose to the radiation worker? It is frequently asked question. It is up to 20 millisievert per year. What are the advantages of TLD batch compared to film batch? It has linear dose response and it is sensitive to low doses and it is reusable. And disadvantages are there. There is no permanent record and there is no instant reading like electronic reader. So it has no instant reading. Now coming to the parts of the TLD batch, one is open window, next is plastic window, next is metal window. Why is the open window necessary in the most below part? It is because it has no filter, all rays pass through it. In the middle window, it is made up of plastic. Alpha rays, which are the heaviest of all radiations, is blocked by the plastic filter. Next, 1 mm copper and 1 mm aluminum constitutes the metal filter. Here only X-rays and gamma rays pass through. It is used for measuring the radiation dose. Now coming to film batch, it can also be asked. Here there are 6 windows. They are no filter, plastic filter, cadmium, thin copper, thick copper, lead filter. Everyone has its own purpose. So we have to know these things, and sometimes color can be asked. What is green window made up of and what is the purpose, like that things. So coming to next station, identify the device. Lead apron. So what is zero lead apron? Anyone know about zero lead apron? We all know that lead constitutes lead apron. But in some cases, bismuth, it is given by the numeric tab. T for tungsten, antimony, bismuth and barium, tab. So what is the minimum prescribed dose of lead apron? The Atomic Energy Regulatory Board of India gives the guidelines that 0.25 mm lead equivalent should be in the lead apron. Minimum 0.25 mm lead equivalents. It is not only lead equivalents, 0.25 mm lead equivalents. So for persons wearing lead apron, where should the TLD patch be placed? Outside the lead apron or inside within the lead apron? So apart from chest, where else we can place the it can be placed in wrist for interventionist and for while handling radioisotopes in nuclear medicine. So this is directly taken from the ARB website. Please make a note of it. For whole body radiation worker, 20 millisievert per year, average over 5 consecutive years, and in any single year, 30 millisieverts is the maximum dose. For member of public, only 1 millisievert per year. This is very important. Taken from ARB guidelines 2021 updated. Now coming to radiation protection accessories, ARB guidelines are like 0.25 mm lead equivalents for lead apron, thyroid shield and gonad shield. For IVRs, 0.25 mm lead equivalent for IVR, and there should be separate for frame, for plastic frame. 0.25 mm for eye shield and separate for plastic frame. Then lead glass window between the person taking a scan and the wall. It is 1.5 mm lead equivalents. Lead glass window should be there. So we should know about all these lead equivalents. Coming to next station, identify the artifact. It is the most common seen next to ghost artifact. Yeah, it is wraparound artifact. Why is wraparound artifact happening? Whenever there is small FOV compared to the anatomical part being imaged, it results in wraparound artifact. So what are the, in any MRI artifact, most common questions asked are, what is the cause for artifact, what are the axes, either it is phase encoding axis or frequency encoding axis, and what are the steps to eliminate this artifact. These three are very important for each MRI artifact. Here we can see, axis for this wraparound artifact are both phase encoding and frequency encoding artifact. So we should know how to eliminate this. Already I said that when the FOV of the anatomical part being imaged is very small, we should expand the FOV. So it can be corrected by phase wrap, that is increasing the FOV, and frequency wrap, that is low phase filters. So coming to next artifact, what is this? This is the most commonly encountered one, motion artifact. It is also known as ghost artifact. So causes motion, axis for this artifact is always phase encoding artifact. For wraparound artifact there was two axes, phase encoding and frequency encoding. But for motion artifact it is always phase encoding. In lumbar spine cases also we may see aortic pulsations causing motion artifacts in within the spinal canal. How to eliminate that aortic pulsation artifact? That by changing the phase encoding axis. So phase encoding axis is the only axis causing this motion artifact. So how to correct? Change in the phase encoding direction. In lumbar spine MRI, to reduce motion artifacts due to aortic pulsations, we should change the phase encoding direction from anterior to posterior to cranial to caudal. So phase encoding direction is changed, so ghost artifact is eliminated. Now coming to next station, identify the device. Whenever they show this plain white like thing, it is intensifying screens within the cassette. Intensifying screens. So what is the purpose of intensifying screen? To increase the number of light photons and to decrease the MEAs to decrease the patient dose. What are the layers of intensifying screens? Base, reflective layer, phosphor and productive layer. Within these four, phosphor is the most important one. What is meant by phosphor? It is the component within the intensifying screen which converts the incident energy into some other form of energy. That is, it is a scintillating material. We all know that scintillation term means light, emission of light is scintillation. So whenever X-ray beam falls into it, it will emit light. So it is converting X-ray energy into light energy. So what is the action of phosphor? Absorbs X-ray photon and converts into visible light. Commonly used phosphors are calcium tungtate, rare earth elements like gadolinium oxysulfate and lanthanum oxybromide. Gadolinium oxysulfate is the most recent rare earth element. What are the rare earth phosphorus advantages? It is faster, higher absorption and higher conversion efficiency. These are the advantages compared to conventional calcium tungstate material. So coming to next station, identify the device. Yeah, it is cassette, radiography cassette. Here, where is the locking system placed? Always on the back side. Here we can see two locking systems on the back side, top and bottom. So what are the types of cassette? Is it single screen, double screen, curved cassette? Double screen is used in conventional radiography, single screen in mammography. Curved cassettes are used in OPG, dental radiography. So coming to differences between radiographic cassette and CR cassette. In the CR cassette, the locking system will be placed near the barcode. Here we are seeing the barcode. Adjacent to this barcode, there will be locking system. This is the basic difference in radiographic cassette and CR cassette. So this is the CR cassette. The locking system is placed always near the barcode. This is the easiest way to differentiate in exams between conventional radiographic cassette and CR cassette, computer radiography cassette. So what is the composition of CR cassette? doped barium fluorohalide. We all have to remember this. Europium doped barium fluorohalide. Coming to spatial resolution of CR, it is only 5 to 8 line pairs per millimeter, but it has excellent contrast resolution. So how do you calculate the speed of CR system? It is by measuring the IP per hour. What is IP per hour? Number of imaging plates read per hour by this system. IP means imaging plate. The other name for this cassette system is imaging plates. So number of imaging plates per hour is the measure to read the speed of the CR system. So coming to next station, it is most common device asked in Viva also. It is a grid. What is the purpose of grid in physics? Yeah, correct. To prevent scatter radiation. So how do you align the grid? The center of the grid and center of the cassette should align straight to each other. So what is the grid ratio? It is the ratio of height of the lead strips to the intergrid space distance. So this is the basic structural component of LEDs. This is the height of the grid. The space between two grid components is the interspace distance. So ratio of height of the grid to interspace distance is grid ratio. The most commonly used grid ratios are for less than 90 kb 8:1, for greater than 90 kb 12:1. Various types of grids are classified depending upon the patterns, grid orientation, grid pattern, grid movement and all. What are the parameters to evaluate grid function are primary transmission and contrast improvement factor and Bucky factor. These three are very important. Primary transmission, CAF and Bucky factor. Coming to next, this is the most easiest of all radiology physics OSCE. Identify the device. It is not sufficient to just mention X-ray tube. It is the rotating X-ray, rotating anode type of X-ray tube. Why it is rotating? Here we can see the radiological right is cathode, radiological left is anode assembly. The anode assembly usually has a long stem. Okay, this long stem is made up of molybdenum. Here we can see on disc in the anode side, it is made up of tungsten, target material. So this is the rotating anode type of X-ray tube. Not you have to mention the full name while writing in exam. Composition of this tube is cathode assembly, rotating anode assembly and glass envelope. Purpose of rotating anode is for heat dissipation. Compared to stationary anode, in rotating anode there will be more heat dissipation and there will be more lifetime for the rotating anode material. What is anode disc made up of? It is made up of tungsten 90% and 10% rhenium. So it is a tungsten and rhenium alloy. What makes the cathode assembly? We all know it is tungsten filament and electrostatic focusing cup which is made up of nickel. Why is the cathode filament made up of tungsten? It has basic three properties. They are very high melting point which is 3370 degrees Celsius. We all have to know this melting point by God. We have to know atomic number of tungsten, barium, iodine, gadolinium, all four atomic number and melting point of tungsten. And what constitutes the glass envelope? It is made up of silica. And what causes browning of the glass envelope? It is due to deposition of tungsten vapors. So this is the cathode side, this is the anode side. Anode side is usually very long because of molybdenum stem. What are the newer developments in X-ray tube? It can be asked in recent advances. They are monopolar tubes, rotating envelope tube and ceramic tube. These three are the recent advances in rotating anode type of X-ray tube. Coming to next station, identify the spectrum. It is molybdenum spectrum. Where are we using molybdenum target in radiography? In mammography. So what is the next, what is the filter material in mammography? It is also molybdenum. In conventional radiography, copper and aluminum are used as filter, but in mammography it is moly for mammography, triple M. So coming to filters, it is molybdenum. For thicker breast, rhodium target with the molybdenum filter can also be used. And next thing is, there should be shorter focal spot for mammography. It is 0.6 mm. All remember this, 0.6 mm focal spot size for mammography. Next, what is the tube exit window in mammography made up of? It is made up of beryllium. Whereas in conventional radiography, it was made up of glass. In mammography, it is beryllium. For conventional, it is glass. Identify the device. It is cone, it is cylinder. So they are beam restricting devices. So the purpose of beam restricting device is to reduce the patient exposure and for magnification. Where are they commonly used in radiography? For mastoid, cella, for magnified view purposes and also for L5S1, lumbosacral junction X-rays. Coming to next station, identify the sequence, MRI sequence. It is the one which we commonly use to identify edema in MSK. Stir. What is stir? Short tau inversion recovery. So when is the inverting pulse applied in stir sequence. When is the inverting pulse applied? Before 90-degree pulse or after 90-degree pulse? Before 90-degree pulse. The name itself says inverting pulse. It should be the minus 180-degree inverting pulse should be applied before the 90-degree exciting pulse. So, purpose of applying inverting pulse is to convert the net magnetization vector from positive side to negative side. It is the basic purpose of inverting pulse. So, what is the inversion type for stir sequence? The name itself says short tau inversion recovery. The name short refers to only 30 to 50 millisecond inversion time, whereas flare is long inversion time recovery sequence. For suppressing water we use flare sequence, no, that is long inversion time. So stir is only short, it is 130 to 150, whereas flare is 1500 millisecond. So the next question that can be asked is, what are the various types of fat suppression that can be employed in MRI? They are frequency selective fat suppression, stir, Dixon technique and in-phase out-phase technique. So basic difference between stir and flare are short TA, long TA, combined T1 and T2 effects in stir and T2 weighted imaging in flare. I have to ask one important question here. Can we use contrast enhanced imaging in flare sequence? Yes, contrast enhanced sequence can be done for flare to detect meningitis, but for stir we cannot employ contrast enhanced imaging. Identify the sequence here. MR enterogram. What is the sequence employed? This is Fiesta. Fiesta or Trophy, depending upon vendor. So what is the type of sequence employed in Fiesta? It is gradient echo based sequence, balanced steady state free precision technique. Steady state sequence, GRE sequence, it is Fiesta. Why are we using this Fiesta sequence for bowel MRI? It has good resolution, okay. But why are we employing for cardiac MRI and bowel MRI? Because it is a very fast sequence and it eliminates the motion artifacts induced by cardiac motion, cardiac pulsatility and bowel peristalsis. So advantages of a star, it is a very rapid sequence, it can be done in breath hold. That is why we are employing it in cardiac MRI. And what are the cartilage sensitive sequences is a recent advanced question. What are the cartilage sensitive sequences? Anyone know of cartilage sensitive sequences? Medic. Have you heard of MEDIC? Okay, MEDIC and DES, MPGR are cartilage sensitive sequences. They are all GRE based sequences. Why it is cartilage sensitive is it enhances the contrast difference between the fat within the bone marrow and the cartilage, which appears usually bright. This cartilage sensitive sequence it is MEDIC. It is routinely used in cervical spine MRI in trauma cases to find the hematoma. This MEDIC or MERS sequence depending upon the vendor, and this sequence is dual echo steady state imaging, DES, DESS. Make a note of it, DESS, dual echo steady state. It is a cartilage sensitive sequence. Here the cartilage is pretty bright here. Cartilage is bright and the bone marrow is suppressed, which appears black. So the contrast is very good here. Dual echo steady state. So identify the material used here. What is this actually? Radiographic film. So what is the color of this film? It is blue. It is pretty blue here. The front one is pretty blue. Why it is appearing blue? Have anyone thought of why it is appearing blue? Because they are unexposed but processed. Whenever the film appears fully blue, it is unexposed and processed. When it is appearing green, what is it? It is unprocessed film. Green color film is unprocessed film. Blue color film is unexposed but processed. This blue color is due to plastic base material within the radiographic film. So we have to know what are the steps in film processing. They are developing, fixing, washing and drying. Before going to exams, you have to know all these things by God. Developer agent, fixer agent and washing and drying. Developer agents constitute all these things. Solvent, developing agent, preservative, alkali and anti-fogging agent can be remembered by a mnemonic SDPR, SDPAR. Solvent, developing agent, preservative, alkali. There, hydroquinone is the most important thing here. It is the developing agent. Hydroquinone or phenidone can be used. So coming to next station, identify the material I am holding in hand. It is a MRI contrast material, gadolinium. Which generation does gadolinium belong to, and what is the type of cycle within the gadolinium component? So gadolinium based contrast agents can be divided into linear, macrocyclic, ionic, non-ionic. We all have to know about these classification. So So this is a vial containing 10 ml of gadolinium, which is a linear non-ionic substance. So what is the routine dose we employ in contrast enhanced MRI? It is 0.1 millimole per kg. We have to know the lethal dose also 6 to 30 millimole per kg. And we have to know about hepatobiliary specific contrast agents. They are gadoxetate disodium and gadobedine disodium, gadolinium bopta, gadolinium EOB. So we have to know about the biliary excretion rate of each component. For gadolinium bopta, it is only 2 to 4% biliary excretion, and the image acquisition is usually done at 90 to 120 minutes. We all tend to remember that contrast enhanced MRI is routinely done within within seconds of administration. But for hepatobiliary specific contrast agents, they are done only after 90 to 120 minutes for gadolinium bopta, which is available in India, and gadolinium EOB, it is done at 20 minutes post contrast administration. So this is the classification of gadolinium based contrast agents. This has to be remembered, and then the question may proceed to which one is more stable. So for stability, ionic is more stable than non-ionic, and macrocyclic is more stable than linear. This has to be remembered. Ionic and macrocyclic are more stable. So coming to next station, which is basically true or false. In patients with no evidence of AKA and with EGFR greater than 30, there is no need to discontinue metformin. It is true or false. But before going into this true or false, can metformin be used for renal failure patients? Can metformin taking patients, can they be exposed to contrast agents? If no, why? If yes, substantiate. So metformin causes renal failure. It is true or false? It is false. Metformin doesn't cause renal failure. It causes lactic acidosis only. So metformin is contraindicated because it causes lactic acidosis, and gadolinium can be employed. Gadolinium is safer than iodinated contrast material in pregnant patients. It is true or false? False, because according to ACR guidelines 2021, see this box here, we do not recommend withholding the use of iodinated contrast in pregnant patients. It is ACR 2021, and the same manual states that because it is unclear how gadolinium based contrast agents behave, they can be administered with caution. They are highlighting the term with caution for gadolinium, but for iodinated contrast agents, they are not holding any caution. But for gadolinium, they are highlighting it as with caution. This is taken from 2021 manual. It is getting updated every 1 or 2 years, so we have to go through before the exams. So coming to this Doppler image. Doppler shift is directly proportional to angle of inclination. True or false? Doppler shift is directly proportional to angle of inclination. True or false? What will happen if you incinate the beam directly perpendicular 90 degree? There will be no Doppler effect. So as long as we increase the angle of inclination, Doppler effect will be negated. So it should be kept as low as possible within 0 to 30 degree. Why? Because in this formula, cos theta is happening here. So cos 30 is greater than cos 90. That is why 0 to 30 degree is the sufficient angle. How will you correct aliasing on correct Doppler? By increasing the pulse repetition frequency and lowering the ultrasound beam frequency. So increasing the PRF is important. What is Nyquist limit? Detectable frequency shift is called the Nyquist limit. Coming next station, this ultrasound based contrast agent, SonoView. So SonoView belongs to second generation of ultrasound based contrast agent. Ultrasound contrast agents are not contraindicated renal failure. Why? Because the route of excretion for SonoView is gas. It is made up of gas. So they are excreted via lungs, not via kidneys. And the constituent also has stabilizing agent. This stabilizing agent is excreted via liver. So there is no role for liver in excretion of USG contrast agents. So you are not supposed to contraindicate USG contrast agents for renal failure patients. So coming to mechanical index, you have to know about mechanical index while using contrast agents for ultrasonography. They should be kept as low as possible according to FDA guidelines. FDA guidelines state that MI should be less than 1.9. Coming to next last station, identify the image. What sequence is this? MR spectroscopy. Yeah. What is Hunter's angle? Here Hunter's angle is normal or abnormal? Abnormal. Why? Because NAA should be the tallest and choline should be low. The Hunter's angle should be like this. Hunter's angle should be like this. But here it is like this. So Hunter's angle is reversed. So what is the principle of MR spectroscopy? It is based on chemical shift effect and how are water molecules suppressed in MR spectroscopy by applying chess sequence. chemical shift selective water suppression. Chess. Chemical shift selective water suppression. Last, what is this ultrasonography mode? No, not M mode. Yeah, it is B mode. And what is the part being imaged? This is the last station. This is lungs, lung ultrasonography. And what are the straight lines? Straight. What is A line, what is B line, what is C line, what is D line, what is G line? So there are two types of lines in lung ultrasound. They are A lines and B lines. We have to know A lines are normal lines, B lines are abnormal lines. These are B lines, they are abnormal lines. These B lines are seen in case of ARDS, pulmonary edema consolidation. So whenever there is fluid interacting with the pleural surface, this B lines happen, like seen in ARDS, hyaline membrane disease, pulmonary edema and consolidation. So it is abnormal B lines. What is the cause of this artifact, these lines? They are due to high acoustic mismatch at subpleural level between interlobular septa and pleural surface. Just mentioning it in simpler terms, it is seen in pulmonary edema, ARDS, consolidation. That is the basic definition here. What are A lines in lung ultrasound? They are normal horizontal equidistant lines. These lines are normal lines, horizontal equidistant lines. These normal lines, A lines. But B lines are abnormal lines. This is enough. Thank you so much.
Thank you, sir, for your very interesting and interactive session. You really made physics a cakewalk for us. Now, I request Dr. Gopinathan, sir, to felicitate Dr. Rajkumar.